Assalamu alaikum, and how exciting it is that you've got Ramadan once again upon you. I'm grateful to the organisers for inviting me to share with you some thoughts today about how we can improve patient care in Bangladesh. I have to declare a conflict of interest that I'm a chairman and CEO of a joint venture company here in Bangladesh, trying to bring the new level of diagnostics you heard Joanne just talk about a moment ago to Bangladeshi patients to inform us for our treatments that you've been hearing about all day. And at the bottom left-hand corner of this front slide, you'll see something called an ISO 15189-2022. And it's a symbol you may not be familiar with, but it's going to be desperately important for clinical practice in Bangladesh over the next several years. This is the highest standard for diagnostics. This requires expertise at the technologist level and the quality management level that the pharmaceutical industry is very familiar with. But we clinicians, and particularly those in the histopathology, molecular pathology world, need to be able to assure the doctors and the patients that the tests that they are making, the results that they see in front of them, that making the treatment decisions about are the right ones. In the Daily Star, December 24, and in the financial press, there was a series of articles about the amount of money, taka, that is flowing overseas. And now that there are restrictions on patients going overseas for treatment, we have to work out the best way and use that as an opportunity to improve the ability for patients to get treatment here. So, as you've heard today, one of the really interesting things about Bangladesh is we really do not know the true incidence of a true protein classification. And we get the sense that there is a higher incidence of what we call triple negative or quadruple negative breast cancer in Bangladesh. Certainly, talking to clinicians over the last 8 years since we've been here, there's a much younger age of onset, reflecting the younger age of the population, but a really tough series of discussions to have with young women. And this is a simplified treatment overview of what we've been hearing about today, but I want to emphasize just a couple of points. Almost all of these rely on a molecular diagnosis for the treatment. So breast cancer is the poster child of the innovation of molecular diagnostics and therapy. And as we alluded to several times in the talks today, molecular switching between the neoadjuvant, the adjuvant setting, the metastatic setting, particularly first and second line, creates a conundrum for the treating clinician, because unless we know what we're dealing with, we're prescribing sometimes exceedingly expensive molecules for no benefit. And the complexity of this paradigm has bedeviled all of us. Those who are old enough, when I first started in breast cancer, you are ER positive using a ligand binding assay, and you are ER negative. Dennis Slayman hadn't described HER2. We didn't understand the Lynch syndrome that Joanne was just talking about, or the BRCA1, BRCA2. We knew there were familial aggregations. But nowadays we think of advanced breast cancer in its many and varied forms and its complex isoforms. What is the molecular spectrum at the genomic, epigenetic, transcriptomic, indeed proteomic level in Bangladesh? And we have spoken endlessly with all layers of your government to impress upon them the desperate need to understand this and to work with the international consortia to define what bedevils women in this country. And I'm going to make one plea to the surgeons in the audience and the radiation oncologists to start establishing molecular tumour boards. Patient care is best when you have all the caregivers in the room together. Without those individual contributions coming together, patient care can be fractured. And already we know getting a woman to present, undergo definitive therapy is a real challenge in Bangladesh at many, many levels. These tumour boards increase efficacy, reduce toxicity, maximise cost effectiveness, and can create a minimal disruption to lifestyle. So we need to develop some resource stratified guidelines. We can take the NCN guidelines, the ASCO, but I'm in particular favour of the SGAT, the guidelines from Europe, which combine not only clinical effectiveness at a statistically significant and clinically meaningful level, but also cost effectiveness. The famous example is the FDA approved a drug for metastatic pancreatic cancer that improved median survival by 4 days, because the FDA is not allowed to mandate on price. If you meet the statistical criteria established when you're talking to them about developing a clinical trial, if you make that threshold, then you get approval. The treatment cost $10,000 US per cycle, and that was in 1995. So let's look at the transformative effect of the impact of cyclin D-dependent kinase 4/6 inhibitors. And it was an Australian, Robert Sutherland, with Elizabeth Musgrave in Cardiff, who actually worked on the biology of this in the early 1980s. But we have seen differences in how these drugs behave. Not only subtle differences between the classes, and Nick this morning was talking about the differences between ribociclib and abemaciclib, and perhaps palbociclib is not so good. You've got 2 conflicting papers, one in the JCO that says there are those differences, and one from Hope Rugo where there are over 10,000 American women and they can't spot the difference. So a pragmatic approach in this country is, if you can get access to those drugs through the pharmaceutical industry, use those drugs. So here is an example that was published just a couple of days ago, where they looked at the impact of PI3 kinase inhibitors according to race. And they could see differences in progression and overall survival based on your Afro-Caribbean heritage as opposed to your white Caucasian. And so we really need, on the right-hand panel there, to look at integrating all of the molecular information to get a better understanding of what Bangladeshi women face. Why is that important? Well, you also heard before discussion about the environmental impact on breast cancer causation. Obesity, premature menarche, delayed menopause, alcohol, reducing parity. These are environmental factors that are dramatically affecting the young women who have grown up since 1971. They are facing a different environment. When we sit down to have traditional Bangladeshi food versus the fried version, we are looking at a different impact on the human female phenotype. So let's get a little bit practical about the impact of these drugs. And we talked about Sonia earlier this morning, but Young Pearl is another important study from Korea that demonstrated that when you compared single-agent capecitabine with CDK4/6 inhibition, the combination endocrine therapy was superior. In the Right Choice study that was just presented a couple of weeks ago at San Antonio, when you have CDK4/6 inhibition, available here in Bangladesh, compared to doublet toxic chemotherapy that is expensive versus outpatient, endocrine therapy wins. So it's very hard to justify using chemotherapy in the first line of metastatic breast cancer. But what about the resistance mechanisms? Can we pick the winners? Can we know which women are going to get the most benefit from the addition of these drugs, or women who may need endocrine therapy alone? So we have good descriptions of the mechanisms of resistance to CDK4/6 inhibitors, particularly retinoblastoma protein loss and amplification cyclin E. So if we measure those, then we can counsel the patients, we can observe the patients, we can change the patient management in line with their prognosis as well as the predictive value of the drugs. Now, pathogenic estrogen receptor 1 mutations were first described by Angela Brody in 1987. Nobody took much notice of that when Angela's PhD student published her data and presented it at San Antonio. And we thought the incidence of this was tiny because they were looking at primary tumours. So ESR1 mutations in the primary tumour setting are relatively rare. But once you get your metastatic disease, whether it be early or late de novo disease, you see these clones of ESR1 mutations cells grow. So much so that it's up to 40% of women who present with metastatic disease with previous exposure to endocrine therapy carry an ESR1 mutation. And it's just not one point. And as Joanne just said, with the founder mutations in Ashkenazi Jewish women, you only have to look at 3 variants. But here you can see from a lollipop plot, the most frequent variants are spread across the genes that code for the ligand, so the estrogen binding domain. And so we can build drugs that understand these deformed pockets in the protein that target ESR1. We have seen that if you carry an ESR1 mutation, that your prognosis in the orange lines here is significantly inferior to those patients who are wild type. So much so that when compared to a non-steroidal aromatase inhibitor, you're doing dramatically worse. So fulvestrant, developed by John Robertson through the right choice studies and eventually the confirmed studies, showed that this was the new standard of care. But it's intramuscular, and it's not without its toxicities of a sore bottom. So novel oral compounds for selective endocrine response degraders have been developed, elacestrant and some others which we'll talk about. Outpatient, well tolerated, highly active, don't require visits into the hospital. So there was a race in the late 1990s to develop these, and these 4 that have crossed the finishing line represent about 40 that failed through expensive pharmaceutical development programs. And you can see in each of these survival curves, the oral SERD wins. Serena-6, which is camizestrant, in the first-line setting, AstraZeneca has just published a press release on the 27th, yesterday, reporting a clinically meaningful increase in progression-free survival. So that means women need molecular testing for the right drug decision. The Emerald study published at San Antonio in Texas a couple of months ago, compared elacestrant with the second-line endocrine therapies. And what was really powerful about this study was it didn't matter whether you had a short, a medium, or a long disease-free interval on CDK4/6 inhibition, you got a benefit. This drug is available in Bangladesh. The Maintain study suggested that if you switch CDK4/6 inhibitors, you may be able to buy a few months for those women who are ESR mutant, wild type. And the post-Monarch study is really fascinating. This is super expensive, triple endocrine therapy. But what we're seeing with this all-oral outpatient therapy is control of disease for up to 4 years. In a comparison of this new immunosuppressant versus the standard of care fulvestrant, which is 90% of the patients versus exemestane, we clearly showed that it was superior. But for the cost of immunosuppressant, a 1.7-month improvement in median progression-free survival. So cost is going to become a factor when you're choosing which of these agents to deliver. And then, in a much more heterogeneous population now, we've got evolving clones, we've got orange ones and dark green ones and lime green ones and purple ones and blue ones. We've got this whole variation of mutant cells undergoing further chromosomal aberrations. We need even more refined understanding of what the molecular drivers of an individual woman's cancer is. So PIK3CA, PTEN-AKT, is a pathway that many of you may not be familiar with. It's very complex. From where we get the original, am I going to get it? No. Yeah, where we get the original ligand binding, you get a chemical electrical signal through, you get phosphorylation through a cascade of events. Those signals then go to the inside of the membrane that then drive proliferation through the well-recognized pathways. So if you have an abnormality at any point of this pathway, and you can see down here how we can characterize where those occur, you get changes in the protein, and you need to develop drugs that target it. But again, in this next iteration of disease, up to 50% of women will now carry the PIK3CA mutation. So some women are double mutants. And we know from alpelisib, capivasertib, now Inavo, which you heard about earlier this morning, we have a range of molecules that are highly active. What's really interesting is, what is the impact of race on Bangladeshi women? These drugs are actually quite toxic. They raise the blood sugar, so you have to have a diabetologist on board helping to guide whether they need metformin or not to keep the sugars under control. They can cause a nasty rash. My first woman spent 10 days in hospital when she was on alpelisib because she just got this florid eczemous rash. And I remember she had a Han Chinese family, and I didn't know what the grandmother was saying to me, but I understood her tone in brutal Mandarin. So you've heard a lot about BRCA, BRCA1 and BRCA2, chromosome 17, chromosome 13. You are hopefully familiar with the fact that when we get a nick in one of our DNA strands that occurs 10,000 times per day in every one of our cells, a whole host of proteins come along to repair that damage. And that BRCA1 and BRCA2 and the RAD51 are the most important proteins there. If you've got a mutation in those genes, then you're susceptible to developing cancer. And I just want to point out to you that Fergus Couch at San Antonio, now just published in Nature, has defined a much broader range of pathogenic and variants, and that will be updated in our databases. So we hopefully don't have to spend too much time explaining SUVs, as Joanne was talking about, to our patients. So here you are, you've got a mutant. Think of it like 3 legs on a table now. You've got a mutation in the 4th leg. How are you going to kill the cell? So by blocking the PARP, which allows BRCA1 and BRCA2 to bind to the DNA nick, you're literally taking out another leg from the table. So that's what synthetic lethality is. You've got a drug that actually helps that mutant cancer cell commit suicide. So the PARP inhibitor trials are well described in BRCA and Olympiad. You've got olaparib here. Talo is not available at the moment. But look out for the next generation of PARP inhibitors. Much more powerful, much higher response rates, and are going to be used much earlier in the treatment paradigm. So Joanne didn't quite say it, I will. I don't believe any woman should be denied access to BRCA1 and BRCA2 or HRD testing. So now, if we think about it, you've got CDK4/6 inhibitors that have a median progression-free survival of 33 months. You can choose, you can do an oral SERD followed by CDK4/6, up to over 4 years of therapy. If you've got a BRCA mutation, up to 51 months. So what you can see now is that we are piling on a sequence of oral outpatient therapy defined by precision medicine. The antibody drug conjugates hopefully are all very well educated now about how the construct is made, standard antibody, how there are variations and huge patent wars over the linker sequences, and how we take highly toxic chemotherapy agents we can't give routinely intravenously tagged onto it. And TDXD and TDM1 are revolutionizing medicine at the moment, breast cancer medicine at the moment, and Destiny Breast 06 got after the trial, got FDA approval, TDXD, and shows impressive 7, 6, and 5-month improvements in progression-free survival. but they're not without toxicities. There is an enormous range of drugs, ADC trials that are going to be coming through. But then we have to rely on our old friends, 5FU, the first rationally designed combination single-agent chemotherapy drug, 1948. And we've got other ADCs coming along. HER2 metastatic breast cancer, eribulin, can be given with the combination now. Cleopatra established the first-line setting. TDXD in the Breast03 established the second-line setting. We have this panoply of toxicities. What happens if we give you an ADC that has none of those toxicities? ARX788 is a terribly exciting molecule. In the second-line setting, compared to capecitabine and lapatinib, which is a standard in China, just published these results the other day, but it has none of the pneumonitis. It has none of the fatigue. It has none of the nausea. So I would argue, for a country like Bangladesh, where you can pick and choose, this is a molecule to keep a very close eye on. Another one is parotinib. So in the PHILA study, again, presented at San Antonio, parotinib versus trastuzumab and docetaxel versus placebo, you've got impressive median progression-free survival of 22 months, almost 2 years, on an oral therapy that can be given with subcutaneous anti-HER2 therapy. Like all of these oral tyrosine kinase inhibitors, you get the diarrhea because EGFR1 and EGFR2 or HER2 are shared in the gastrointestinal system. You can get pancytopenia, but no febrile neutropenia, and you get anorexia, nausea, and vomiting. Both of these molecules, TDXD, have seriously high CNS penetration and are able to keep women with cerebral metastatic disease alive. But similarly, these oral outpatient regimens can do the same thing. So again, when we're talking about quality of life, when you've got cerebral metastases and you're on steroids, and you've got the whole family giving up their lives to look after you, being at home is a much better place to be. And then there was the Patina, which was a headline study. It got New York Times, Wall Street Journal, BBC, CNN, and this was in the triple positive patients. So giving palbociclib plus anti-HER2 therapy after induction chemotherapy, 4-year progression-free survival. So we need to really understand the molecular biology of these women's disease in order to build our new algorithms for what is best and what is most cost-effective and what is most care-effective for our patients. Finally, this is a metastatic triple-negative breast cancer you know incredibly well. This is Rebecca Dent, who's now Deputy CEO at NCCS. She and her fellow at the time wrote one of the first papers describing the natural history in 2007 in CCR, and now did this cumulative graph. So that was what we've got to compare it against. But we've really never had a guide to which chemotherapy works best for triple-negative and why. So now we're starting to get genomic studies showing that if you carry BRCA1 and BRCA2, or both, you actually do better with standard chemotherapy. And in particular, on the right-hand side, you'll see with the blue line, exquisite platinum sensitivity. So molecular profiling can also start helping guide which is the right chemotherapy. Peter gave an elegant discussion of 355 and 522 today, so we will not repeat it, but I'm going to share with you the complexities of getting the right diagnosis. If you think ER, PR, and HER2 immunohistochemistry is complicated, wait till you get our pathologists doing on PD-L1 expression. And in fact, we fly the pathologists out to Australia to train them on the best way of measuring PD-L1 expression. There is a new technique coming along that measures the interaction between PD-1 and PD-L1, and that is much more sensitive and much more predictive benefit of these agents. In the metastatic setting, we've got 130, 131, and 355. But I want to highlight the Torchlight study of torilimumab. Torilimumab is 10% of the price of pembrolizumab. It demonstrates exactly the same clinical benefit, and it can be given over a shorter infusion time. So this is where competition in the pharma market space is going to be terribly helpful for countries like Bangladesh to get maximum bang for their buck. I just want to add a word of caution. These drugs give lifelong toxicities. The strongest measure, clinical measure, of benefit in the adjuvant setting of PD-L1 inhibitors is thyroid dysfunction. The pneumonitis, dermatitis, there's not an organ system in the body that is not affected by these drugs. So when you're prescribing this in the adjuvant setting, please consider your patient. So PARP inhibitors now in the metastatic triple-negative setting can also be expanded to PALB2. And you can see from these waterfall plots that you get dramatic benefit here. So we're extending the portfolio, and we've already seen in some of the molecular studies we're doing here in Bangladesh, there is another agent that will be susceptible to PARP inhibition that will publish or hopefully present here next year. I have to mention the TROP2 directed ADCs, expensive, challenging toxicities, but certainly on the pharmacopoeia that you need to know about. And of course, molecular switching within triple-negative breast cancer bedevils us all, and we have to consider potentially the role of liquid biopsy in years to come. We've got the rarer agnostic drugs, as you heard before, not very common in Bangladesh, we know. So to do all this molecular profiling is not an easy task. You have to get trained technologists to extract the DNA properly every time. You have to get specialist reagents with exquisite sensitivity to use that minimal amount of DNA that may come from a core biopsy or from an acidic tap. You put it through a sequencer, which is not an inexpensive machine, and I know because I've blown one up. And then you have to go through even the more complicated primary, secondary, and tertiary analysis. So the primary analysis is what's done on the machine to say, is there an aberration here or not? The secondary analysis says, oh, look, let's check all of these aberrations. Are they pathogenic or not? And the tertiary analysis is the one that matches the aberration with the approved pharmaceutical. And this is something that was performed in Bangladesh. Here is a woman who has a TP3 pathogenic aberration. She's got a pathogenic BRCA2 aberration, all done within an ISO 15189-2022 protocol. So my final slide is to give you a little cast into the future. Where is precision medicine going? Bangladesh can't afford CAR T cells. It can't afford tumor-infiltrating lymphocyte therapy. It's $1 million a patient. It can't afford Protacs. They're $50,000 a year. An mRNA vaccine costs $5 to make. And this survival plot shows the publication in Nature just a couple of days ago of 8 patients who received an mRNA vaccine for metastatic pancreatic cancer. 4 of them are still alive 3 years later. So tumor-informed mRNA vaccines, oncolytic virus vaccines such as adeno-associated virus or vaccinia, etc., I think are going to be a highly cost-effective approach for a country like this. And just a couple of days ago, Nanjing University in Japan demonstrated a new methodology where we can get prolonged exposure and expression of these proteins within the nanoshell. And finally, you can't give a talk nowadays without mentioning artificial intelligence. When Jason Huang, the CEO of NVIDIA, the world's most valuable company right now, says that he is focusing all of his attention on revolutionizing healthcare in cancer, we should all listen. Thank you for your attention.